Well, it's really an honor and a privilege to address this group, especially on the occasion of our 5th birthday here. I think birthdays are always an occasion for reflection, and 5-year anniversaries also. One thing I've learned from the journalists in my life is that if you want to get people thinking about something, try to put it in sort of concrete terms, like, you know, how many jumbo jets crashing every year is equivalent to the number of medical errors that happen in hospitals every year. Thanks, Alex. So to kind of put our 5-year anniversary in perspective, this is my son, Evan, at the time that we were awarded the grant to start this program. And here he is today. You know, in 5 years, a lot of growth and amazing changes can happen, and that's certainly true of our program and our field of public health law research. So I think it is an opportune time to reflect on where we've been, why what we're doing is important, and where we should be going in the next 5 years and moving forward in our field. So I want to spend some time thinking about that today, and I think it really starts by thinking about our mission itself in public health law. Researching public health law is only important to the extent that the law itself is doing important things in society. So I want to reflect a little bit on some of the challenges that confront public health law as a field at this point in time, what we could be doing to help that field grow and mature. And then I'll conclude with some reflections on the progress and challenges that confront the field of public health law research and some of the critical opportunities for us going forward. But let's start with the mission. You know, why focusing on public health law is a worthy choice for our energy and attention. Our mission in this program of PHLR is to really build the evidence base for regulation, law, and policy to promote public health through discovery and through translation of knowledge. And that's critically important, I think, at the simplest level because health is important. But we live in a cultural context, and particularly in a political moment, where our focus on government as a solution to health problems requires some justification. So when we answer the question, why is public health law important as a vehicle for health improvement, I think we really have to reach towards our sort of growing mutual understanding that the private mechanisms that we might rely on to get the kind of health outcomes we want frequently fail us. You know, it's fashionable these days to argue that we'll get the best decisions and the best outcomes by just having government stay out of people's lives. Empirically, unfortunately, we know that's usually not true, or often not true. That markets fail us a great deal in the health arena, that often what's individually rational for each of us doesn't produce optimal social or population level health outcomes, and that for all kinds of reasons, we each of us fail every day in making and carrying out health promoting decisions for ourselves and our families. And so I think there is an argument, but it's ours to make, as to why there is a role for law and for government in helping people achieve the highest health that we can have. And so our task is to really understand when these market failures occur. What are the conditions that produce them? What are the mechanisms that are behind them? And how can we correct them through intelligent regulatory action and smarter use of law? That is the case that we're tasked with making, and it's urgently important that we do so. And then it's our task to identify the solutions, how smart regulatory and legal action can help bridge some of the failures that we see in our day-to-day lives in producing health. To put a finer point on it, I think there are at this point a number of justifications that we can offer for the enterprise of public health law. Certainly the most compelling is the prevention of harm to others. That has long justified government intervention, even in quite intrusive ways, to prevent infectious disease, environmental toxins, and so forth. But as we go down this list of other justifications, their controversial nature, I think, increases. Economic externalities are certainly another important argument in favor of action. When we look, for example, at the burden of obesity, it approaches the economic burden of tobacco. Cawley and Meyerhofer made headlines in 2012 with their finding that obesity might account for as much as 21% of medical spending. That's a staggering amount of money, to speak nothing of the mortality and morbidity associated with obesity. So there's a strong argument for externalities here and for corrective action. Informational defects are another justification for many forms of regulation that give people more or better information to make better choices, and certainly there's no better example of that than in the nutrition and obesity realm, where public health action can do a great deal to correct informational asymmetries in the market and still basic misunderstandings that people have about what they need to do to stay healthy. Protection of the vulnerable, parens patriae, the notion that government has a just role in protecting those who are not fully able to make autonomous decisions in the market, is also a strong justification for many forms of public health law, especially those aimed at children. And then finally, and of course most controversially, is the argument from paternalism, which Larry Gostin and Ron Bayers and others have made efforts to press, but which still struggles to find traction here in the United States. In other parts of the world, it's not controversial to assert that government has a role in helping people understand what's best for them doing those things. In this country, it is. It requires a very strong justification. But I think most in the public health community would argue that there is a role for at least benign or corrective paternalism, things that help people bridge the gap between what they know is utility maximizing for them over the long term and what they actually do. And there are all kinds of things we know now from research in behavioral economics and psychology get in the way of people doing the right thing, the thing that they've decided is right. Their inability to effectively forecast how they will feel living under states of future ill health and disability, their tendency to overly discount consequences that occur in the future, and as we saw in the presence of the large birthday cake last night, simple failures of willpower. So there are good arguments for the use of law in appropriate circumstances, when law is imposed smartly and with evidence. And we know that done right, public health law can be extraordinarily powerful. When we look here at the Centers for Disease Control and Prevention's list of the 10 great public health achievements of the 20th century, all of them, Tony Moulton and others have argued, have been identified, enhanced, significantly promoted through the use of law. And it's not hard at all, of course, to think about examples of extraordinarily successful public health laws. One of the best known examples is probably the de-leading of gasoline. Lead was added to gasoline in the 1920s as an additive to reduce engine knock. And over the next few decades, it became apparent that it's highly toxic, and as you probably know, in a number of ways to the human body, but of perhaps greatest concern associated with high levels of mental retardation in children. After a long fight, the EPA started to regulate lead in gasoline in 1973. It got serious about enforcement around 1977, and we subsequently saw just huge drops, both in the levels of ambient air lead concentration, which you see on the left here, and blood lead levels. And I think a very large body of research now shows that this law has saved literally millions of children from the harmful effects of lead. A lesser-known example that comes to us from Alex Wagonar is the alcohol tax. Alex did this very elegant study of what happened in Alaska when the state imposed significant increases in its excise tax for alcoholic beverages twice, once in 1983, once in 2002 here. And what this graph shows is the change in Alaska compared to other states in deaths due to alcohol-related diseases. These decreases are really pretty staggering, hard to believe until you read Alex's paper and have trouble finding a reason not to believe them. And really shows the power of something that, something relatively simple like a tax increase can have on human health. So there are lots of examples of public health going very, very right. We can also, of course, think of a number of ways in which the law can misfire, where we have too much law, the wrong law, or the right law carried out in the wrong way. Law might be incompletely implemented, as is the case with the alcohol excise tax in other states. One of the things that we pointed out recently in our Critical Opportunities paper in the American Journal of Public Health is that this is a great idea that most states have sort of squandered the opportunity to fully leverage, because they've passed alcohol taxes and then let them degrade over time, not adjusting them for inflation. And so by making a simple correction in the way a law is implemented, you could have a really powerful effect, but most states have lost the opportunity to do that. Law can misfire in other ways. One way that we see often is an overly heavy-handed legal intervention. And the area that I know best from my own work is in medical malpractice liability. We've created a sanction through the tort liability system that providers perceive as so punitive and catastrophic that it has effects far beyond that which we want it to have. So instead of producing the safer healthcare that we want, it leads to all kinds of perverse behaviors, the oversupply of healthcare services, putting patients at risk, and according to work that I've done with colleagues at Harvard, contributing to our national healthcare bill on the order of $45 billion a year. And finally, perhaps most concerningly, law misfires when it's not evidence-based. And there are lots of examples of that as well. My favorite is Hosni Mubarak's edict in 2009 in response to the breakout of swine flu there. Well, if flu comes from swine, let's kill all the swine. This, despite the fact that his health experts had advised him that H1N1 was not transmitted to humans from pigs. And in ignorance of the fact that the pigs were an essential component of the urban ecosystems in a lot of Egyptian cities. They were the garbage men of these cities. And without the pigs, the garbage piled up. They brought in these goats to try to eat the garbage. They were not up to the task. And as a result, there were additional health hazards created because of all of this refuse piling up in the streets of Egypt. So law can go very, very right or very, very wrong. What is it about good public health laws that makes them good? This shows kind of the way that I've always thought about it, that there's really three dimensions of a good public health law. Fundamentally, you've got to first establish that it's feasible, which has to do both with what is legally permissible and with what you can get away with politically. Most health law scholarships, as you well know, has been very, very focused on this one little shape here of the legal permissibility of interventions, focusing on what we can do legally. Much less attention has been paid to the politics of public health lawmaking, as well as all of the other things that go into good public health law. The second dimension is that the legal intervention can be justified. Just because we can act with a public health law doesn't mean we should. And there is reasonable disagreement even within our own field here about when government intervention becomes appropriate. Do we need to wait for a massive market failure just to signal that the market is failing? Or are some health outcomes so urgent and so important that we shouldn't wait to see if the market will fail? But some justificatory condition has to be offered, I think, in this cultural context for government intervention. And then it can't also be overlooked that the intervention itself has to be morally just, for example, in its distribution effects, and in the trade-offs that individuals are asked to make, the liberty that they're asked to give up in order to get health gains. And then finally, and I think most central to our mission here in public health law research, the law has to be rational. There has to be some reason to believe that it will work, some plausible mechanism of effect here, and some level of evidence that it should work. The level of evidence needn't, in my view, always be as high as policymakers might assume. In other words, we shouldn't have to have an ironclad case that a law will be effective in order to adopt it. That kind of evidence base can't accrete until we experiment and study. And so part of our mission, I think, is speaking to policymakers about that cycle of evidence accretion, how much evidence is enough, and what kind of evidence should be believed and sufficient for policy action. So this is the goal. And the question is, how do we get here? How do we get to good public health law? I think there are a number of challenges that the field of public health law continues to face. I'll talk just briefly about three of them. And a number of things that we as scholars can do to help overcome these challenges. The first challenge, I think, clearly is retargeting. So public health law has been around for a long time. Its roots are as ancient as our country itself. But historically, its focus has really been on the prevention and control of infectious disease and the control of environmental toxins. Over the last few decades, we've seen greater forays into injury prevention. But today's big health juggernauts are different. This work by the University of Washington shows the contributions that different types of health conditions play to deaths in the United States. In the red at the bottom is infectious disease, lower respiratory infections being the big one there. The little sliver at the right is injuries, and the rest is non-communicable disease, cancer, stroke, COPD, ischemic heart disease. These are the big killers. And public health law is a relative stranger to these health threats. So the challenge is to refocus attention here, to make the case that public health law should be focusing here, and to find ways to be effective here. And that last part is really the kicker. In many ways, these are much harder health threats to address at all, and then to identify appropriate interventions through law for. The underlying health risks or behaviors that contribute to these chronic diseases are listed here. Again, anything you see in blue is a non-communicable disease. So the health risk behaviors and conditions that are contributing to deaths today, for the most part, are really hard ones to think about how to ameliorate, especially through law, but at some level at all. For example, with dietary risks, we still lack sort of basic public health science about how to be effective in changing people's behavior in that realm. And then there's the meta question of how do you do it through official action. So this is hard, but I would argue very important. Perhaps the most important thing that we can do in public health law is to retarget our attention on the new killers. I think public health law research can help in this. I think one thing we can and should continue to do is to draw attention to innovations in legal interventions that seem promising, although the evidence base is going to be limited in part because it is new. And perhaps just as important for us, it's important that we retarget our attention. We're always led as scholars to our own areas of interest, but I think at some level we have a responsibility as a research community to set our agendas in a way that reflects these health risks and focuses in on how we can make the biggest impact on these health threats. So the first big challenge, I think, for public health law is retargeting. The second really has to do with winning over the hearts and minds of the public. And in more generally speaking, the conundrum of how intrusive we should allow public health law to be. There's one story that I've become acquainted with recently I think illustrates the point nicely. This nice-looking young physician is Dr. Nirav Shah, who recently became the health commissioner of New York State. He's an academic physician by training, a newcomer to politics. And he inherited a mess. And the mess was that in New York State, only about 48% of healthcare workers got a flu shot. And his predecessor, Dr. Richard Daines, had taken the tact of imposing a very controversial mandate to get a flu shot. This was going to be a condition of employment for healthcare workers. And it was a political disaster. It was perceived as incredibly heavy-handed. There was literally protesting in the streets. The unions got involved, and he eventually had to retract the order. Shah then swung the coercion pendulum completely in the other direction, using this photo opportunity here. This is Governor Mario Cuomo getting his flu shot. Perhaps not surprisingly, this, aw shucks folks, that didn't hurt at all, photo did not have the desired effect either. And so Dr. Shah then swung back towards the middle, and his newest idea, which was implemented this fall, was something in between a nudge and a hard shove. So if you're a healthcare worker in New York State now, you don't have to get a flu shot. But if you don't get one, you will be wearing a hot, uncomfortable surgical mask all day long as you see patients. So it remains to be seen whether this will work, but I think it illustrates a couple things. One is the range of potential mechanisms and the need to think creatively about what official action can do to encourage behavior changes. And the other is the risk that we run when we're overly heavy-handed in legal interventions of not just undermining the goal of the policy itself, but undermining official legitimacy. That when government again and again does things that are perceived by the public as too intrusive, not morally and legally and economically justified, we hurt ourselves in our ability to do things in the future along the same lines by undermining official legitimacy. And legitimacy, of course, also affects people's willingness to comply with the law. We know that from areas of research as diverse as criminal procedure, taxes, enlistment. So this enterprise of finding ways to justify official action to the public and maintain legitimacy, I think, is critically important. And it's especially important in the realm of non-communicable disease, which, again, is new. The notion that government is going to be involved in this area of health behavior is far from being accepted and provokes backlash that, again, hurts not just those individual attempts to intervene with public health actions, but the more general enterprise of public health lawmaking. And just, I think the best illustration of that is the way that Mayor Bloomberg gets talked about in the popular media today. It's not about any one policy, but about him and his administration and their political agenda being incredibly intrusive. So what can public health law research do to help with this really important project? I think one is for us to keep an open mind about identifying and studying the full range of potential legal mechanisms. The focus of legal scholarship has always been mostly on hard law, on public law. We need to be inspired by recent scholarship on nudges, on co-regulatory strategies, be thinking about this whole Braithwaitean pyramid and what the right approach is, and how can we show what can be done with a range of legal mechanisms. And then I think the second thing we can contribute is research on legitimacy itself. That's an interest of mine, and I think we do have now a small but useful body of literature that shows some things that policymakers can do to try to enhance the legitimacy of official action, some of which have to do with policies themselves and some of which have to do with processes, like engaging the public early on. There's one more challenge that I think public health law faces, and that is really the challenge of getting policymaking to be evidence-based in general. This is one depiction of the life cycle of evidence-based policymaking. Sometimes we've seen this work really well. Things like graduated driver licensing laws are a great example of where some initial experimentation was rigorously evaluated, the intervention was fine-tuned, and then widely adopted. Other areas of law, and we can each think of some from our own areas of focus, don't work that way or haven't worked that way. Sometimes it's because evaluations just aren't available, and of course other times it's because of politics or other factors that tend to override evidence when policy decisions get made. So what's our role here? I think one is to try to move to a world where evaluations of public health law interventions are routine, that they're inbuilt to new policy experiments. And we probably play an important role in being the technical arm of that enterprise. And then the second is really to enhance our commitment to getting out there with our research to help policymakers understand what is working and what doesn't, how they should think about different kinds of evidence. And although most of us tend to be good about advocating for the ideas we believe in, I think just as important is being willing to spend time disabusing policymakers of notions about interventions they think will work that we know don't. So these are the challenges, I think, for the field of public health law in general. And let me conclude with a few reflections on our own field of public health law research and the progress that we've made over the last 5 years. A group of us in the Methods Corps wrote an article around 2009 in which we kind of surveyed the state of the field. And these are the major challenges that we identified then for our field. One, improving the methodological rigor of scholarship in this area. Although there was some very good scholarship out there, it was more common to see simple descriptive studies, general inattention to some of the more sophisticated methods for examining empirical problems, and lots of research being done by solo researchers who lacked an important dimension of expertise really needed to study the problem well. Funding was then a very significant problem. Ensuring the stability of that funding stream was really critical to, among other things, fostering the growth of the kind of multidisciplinary teams that would be needed to do this work well, since not everybody has the luxury of operating with their salary covered. Identifying data sources was another big problem. Although there's lots of good health data, finding data sets where the laws have been compiled and coded was almost impossible to do. And then finally, the general project of ensuring that there was an impact of this scholarship on policy was identified as a major challenge. A lot of the scholarship was really inaccessible to policymakers, either literally being locked up in journals that they couldn't read, or cognitively, that it was not written in a way that policymakers could understand or would even be willing to slog through and read. Lots of folks, particularly, frankly, in the legal academy, weren't spending time doing affirmative outreach to policymakers to try to get their research to them. And as a result, there was this general disconnect, I think, between the research in the field and the policy community. So here's what we identified a few years ago. I think we've made significant progress on these goals, even in a short time. And certainly the methodological rigor of the field is the area that we on the Methods Corps look at with the greatest pride. We certainly are not responsible wholly for the improvement in this area, but I think the program itself has offered a number of things. The book that Alex and others wrote on methods, I think, is one thing that has really helped disseminate some of the standards. And that standard setting that has been done within the program and by our own grantees, I think, has really been critical in moving this area of scholarship forward now. When empirical health law research is reviewed now in peer review, these are the methods that will be applied, will be scrutinized. Scholars will be criticized if they're not adhered to. So it's really this community that I think has begun to set the standard. And we've had the happy coincidence of doing our work at the same time that there's really been an incredible explosion in the prevalence of joint degree JD, PhD professors at top law schools, which has provided us with a tremendous potential resource, people who are highly skilled, who have their time covered, and who have the interest and expertise to look at these problems. Finally, I think just the creation of this intellectual community has done a great deal to improve the rigor of the field. The peer review process has been strengthened, both the formal peer review process in journals and the informal peer review that goes on for law review articles before submission, I think has really been strengthened, again, by the growth of this field itself and the standards that have been adopted. We, of course, as a program, have been able to provide a new funding stream, and I think that has been really important in sustaining interest in this field and inspiring those who maybe didn't think of themselves as public health law researchers to enter it. And the program's contribution in producing legal data sets, I think, has also been really significant, and it's exciting to see in the last round of funding our first group of grantees who are doing work using data sets that were created by grantees in our earlier rounds. And finally, I think we can all agree there's much greater outward facingness among this community of scholars than there was even a few years ago. Lots of efforts to make our research more accessible to policymakers, both things that individual scholars are doing and things that the program is doing, like the evidence briefs, and then new structures for connecting the research and policymaker communities like the Public Health Law Network. So I think these are really extraordinary achievements for the program to have achieved in a very short period of time, and I really credit Scott and Jen and Alex and all of the others who've been intellectual leaders of this program, and Heidi for her operational prowess in carrying out this really tentacular expansion of all of these areas of our field. We, of course, have a number of challenges, and I'll close here in thinking about the work that is to come for us. I think we continue to be hampered by our need to rely on observational research to discover knowledge here. Lots of interest in randomized trials, including by the Obama administration, but they're pretty hard to pull off in the realm of public health law. And so we're going to have to continue to work hard to make our studies as convincing as they can be with the limitations of the world as we take it in observational research. While we've made significant progress in providing funding for this field, diversifying that funding stream remains a challenge, and it's an ongoing mission of this program to try to inspire greater interest at NIH and others about including a legal and policy dimension to every clinical and translational science proposal that it funds. Promoting uptake of research findings, I think we've made significant progress, but there's significant work to come here as well. Part of that is our job, to do a better job getting it out there, and part of it really just has to do with the realities of the political process itself. How do we continue to press evidence against other priorities? I think engaging law professors remains a challenge for us. We've attracted many of the best and brightest into our community. There are many others out there who have yet to be brought into the fold. And that'll be a continuing mission of this program, I think. And then finally, I think we're still dealing with some growing pains in terms of the clash of cultures involved in public health law research. I'll just relate one anecdote that was the subject of some discussion among our methods corps a few months ago that I think illustrates what can happen when you have people from different fields working on a common problem. The controversy related to this paper by John Click and Joshua Wright, I don't know how many saw this paper when it came out on SSRN. Their idea was to look at what happened when San Francisco County banned the plastic grocery bags. They were concerned that people don't wash their reusable grocery bags, and so they might be a vector for bacteria. And when they looked at rates of reported deaths due to gastrointestinal illness in San Francisco County compared to all the surrounding counties, they found that the grocery bag ban was associated with an astonishing 46% increase in deaths. And I must say, John Click's a really good economist. When you read his paper, again, it's very hard to find anything wrong with it. And they published this paper on SSRN. The chief epidemiologist from the San Francisco County Department of Health then published a memo. This was the first time he had heard about this study. And he objected to it strenuously. He said, look, this was an ecologic analysis. This was not, it doesn't support causal inference. If you want to infer causality here, you have to do what epidemiologists do, which is you find the people who died and then you trace their exposures back in time. And he also said, if you had come to us, we would have shown you our data, which show the different bacteria involved in these deaths. And you would have seen that almost all of the increase in deaths is attributable to C. difficile. And that's a bug that mostly occurs in hospitalized patients. They go on antibiotics and they have an overgrowth of this bacteria and they die. There's no established mechanism to make us think that this is even foodborne. So here you have two very different modes of causal inference here. The epidemiologist is saying this can't be true because there's no proven biological mechanism. And the economist responded by saying it has to be true because we controlled for everything else. So it turns out the truth is probably somewhere in the middle. If you spend some time looking at this, there's actually some provocative evidence that C. diff might be present on packaged meat. We don't know anything about whether it's present at levels that would pose a threat to human health, much less be lethal. But ideally, this sort of correlative finding from the economist should provoke a good health department to investigate the possibility. And ideally, these economists ought to have partnered with this health department much earlier in the game. To become aware of some of these nuances and to get access to data that might have strengthened their case. At the very least, one imagines the discussion section of this paper would have read differently if they had. So I think this demonstrates a couple points. One is that we still do have some clashes of cultures over what it means to discover something about public health and public health law and what causal inference is all about. And the other is that we have not yet fully sold the idea of multidisciplinary research teams. There are still members of our community who are working in isolation and whose work could be enriched by earlier and better partnerships with the practice community. So how can we begin to overcome these challenges? A few suggestions for the next 5 years of PHLR. One, I think, in terms of promoting uptake of our research and staying relevant, is for us to vigorously pursue our agenda of critical opportunities. And this is the notion of identifying potential legal interventions that respond to a public health threat of great significance, that happen because of a mechanism that's plausibly amenable through law change, and for which we have a plausible, even if not proven, legal intervention. And so that's the task that we'll all take on tomorrow morning, and it's an important mission for our program for the next several years. I think the second thing we can all do is take even greater responsibility to stay connected to the policy world. There are so many things that push our research agendas in directions that are not policy salient. Our own interests, the availability of funding, ideas that happen opportunistically because of colleagues. But I think only by staying in touch with the on-the-ground concerns of the policy and practice community can we remain relevant. Third, I think, is to really be inspired by the mission of lawyers and legal scholars of advocacy, of passionate advocacy of a cause, but to keep ourselves firmly rooted in social science in terms of our approach. And I think that's one thing this community has done extraordinarily well. We can continue to produce evidence at the highest levels of scientific rigor while still being passionate advocates for a cause. And then finally, I'll close here. I think each of us should continue to really draw strength and enrichment from this incredible community of scholars that we've built over the last few years through peer review, mentoring, opportunities for collaboration, and of course, funding. I think we've really provided a platform to grow and to mature our research so that it can make even more important contributions to improving human health. So I'm really privileged to be a part of this community. Thanks very much.